A transthoracic echocardiogram is a very useful clinical test. It's diagnostic, non-invasive ultrasound of the heart. However, it is requested far too often, resulting in delays in getting one. So here's an important guide. Here are the 5 clinical indications to get an echo in an acute hospital setting. Number 1, infective endocarditis with a high Duke score. Number 2, decompensated heart failure, when you don't have a recent echo in the last half a year or so and the patient is not fully established on heart failure medication. Number 3, severe or critical valvular or obstructive heart disease such as aortic stenosis or HOCM, when there are signs of severe disease such as narrow pulse pressure, syncope or heart failure. Number 4 is pericarditis or myocarditis, when there is a pericardial sound in chest pain, a rising troponin, or the patient is hemodynamically unstable. The differentiating feature between an MI and pericarditis is in MI, the troponin will rise and peak quite early, whereas in pericarditis the troponin will continue to rise over the following days. And number 5 is cardiac ischemia or recent MI. Now importantly, here are 5 indications when you should not do an echo in an acute hospital setting. Number 1, an infection of another source. An echo is not used just to make sure it's not endocarditis. Number 2, decompensated heart failure, when it's an exacerbation of known cor pulmonale, or you've had a recent echo in the last half a year or so, or the patient is already established on heart failure medication. Think pragmatic. It will not change your management in the long term. Number 3 is a murmur or syncope, but is not related to the primary presentations. There's no signs of severe heart disease, and the syncope is of another cause. For example, an 85-year-old comes in with sepsis from a UTI. You hear a murmur, but there's no signs of severe valve disease. The murmur is either a flow murmur, or the patient's got mild aortic stenosis because of their age. Or you've got a vagal or postural syncope. You won't do an echo to look for an obstructive cause. So think pragmatic. Number 4, chest pain, but it's not cardiac sounding. There are no ECG or troponin changes. It's not cardiac. And number 5 is an acute MI such as an NSTEMI. You should focus on acute ACS treatment, getting urgent cardiology review to guide an angio based on the Grace score. An echo would only delay your acute management. Hope you found this helpful, and as always, don't forget to subscribe.